Okay, I know what you're saying. Oh my goodness, I know she is not giving me a PowerPoint at this time and on this day, but surprise, I have a few more things I need to wrap up for this test just because we didn't get a chance to cover it in class. And this is the point in your entire nursing school where you will heavily discuss antibiotics. So don't be overwhelmed. I'm just going to point out a few things to you. So let's move. Alright, some of these drugs are majorly appropriate for urinary tract disorders and can be found on page 1371 in your IGGI book. The pharmacology book that you have did have some extra information, so I pulled it over here. So what I would like you to do is pay attention to page 1371 and 1372 and my slides, and you should be good and able to answer any kind of test questions or NCLEX question on this material because it's kind of like the highlight of the highlight. So the first drug class that we're going to cover are some antimicrobials known as sulfonamides. Yes, this is a sulfur drug. A lot of people have allergies to this drug. It is primarily used for UTIs and some respiratory infections, but mainly UTIs. What's great about this is it is 90% effective against E. coli. So remember, most of the urinary tract infections are E. coli. Well, boom, put them on some sulfonamides and they are healed. Thank you. Any of you who are interested in mother-baby stuff, when that newborn comes out, they are actually going to put a whole bunch of antibiotic on that baby's eyes. It's like a Vaseline looking kind of ointment. It is a sulfonamide. So let's keep going. Oh, another thing too that's really neat about these drugs is silver, the medication that we put on burns, actually is part sulfa. So anytime you have a burn patient and you're going to apply the silver cream, know that its base contains sulfa. You must ask them if they have a sulfa allergy. Next. The main drug that you are going to see from this class is called trimethoprim and sulfamethoxazole. Say that one 5 times fast, right? The reason they are combined together is that they have a synergistic effect that causes the bacteria to not develop resistance as fast. So sulfa drugs are often combined with something, and this is the most popular oral one that you will see for UTIs. Okay, big no-nos with this drug. The person must drink a lot of fluid. If they do not increase their intake, they will actually get crystalluria. It could potentially form crystals in their urine, and it can cause kidney problems, as you see evidenced by my renal failure here. So let's make sure that the person knows they must drink. As any drug, we need to make sure that they monitor for a rash or a superinfection. But I mean, that kind of goes for all medications, particularly the broad spectrum kind. No antacids within 2 hours of taking this drug. Hang off on doing that. This is a very popular drug for causing photosensitivity. So your person's going to get a pretty nasty rash if they don't cover themselves. They don't slap on some sunscreen. Watch me slap. Okay. Most antibiotics cause Stevens-Johnson syndrome. So if that's ever an option, just choose it. That's all I got to say there. This is nice to know. If they are in their 3rd trimester of pregnancy, they are not allowed to take this drug. No. The next drug class that is extremely popular are known as the fluoroquinolone drugs. Sometimes you'll hear quinolones for short, but the full name is fluoroquinolones. These are very important to know because they are bactericidal. As the last drug that you looked at, the sulfonamides are more or less bacteriostatic. These are bactericidal, also used for UTIs. And I have also primarily seen them for respiratory infections. So if you come in with some pneumonia, we're going to give you a fluoroquinolone. If you know anything about trying to find some similarities, what are you picking out of this drug class? Could it be the last suffix of these drugs? Correct. Now, quick little story to help this sink in your brain about why we have multiple drug classes and why it even really, not drug classes, why we have multiple drugs in a class that you need to know. I had a patient discharged from Gulf Breeze Hospital on this one. They were told to take the prescription to Publix and get it filled. Next thing you know, a couple hours later, I get a phone call from the Publix pharmacist explaining that the patient is refusing to pick up their drug because it cost $180 for 5 pills. And the pharmacist was inquiring what to do next because she knows that the patient needed this drug. So I went ahead and reached out to the doctor who discharged this patient, and I said, hey, Avalox costs too much. They're a self-pay. Can we do Cipro? It's in the same class. Do you feel that it covers the bacteria? And he said yes. And if you know your Publix free drug program, they actually offer this free for patients. So under the doctor's order, I called a 5-day prescription for Cipro into the pharmacist, and the patient got it for free. So it's interesting how you can be a patient advocate for the, well, I don't know what I could say, for the small things, for what matters. Cost of drugs. Alright, fluoroquinolones. This is extremely popular, as you're seeing with all antibiotics, but especially this one. In fact, if you ever pick up a prescription, there is a big sticker on there that warns you about not taking any kind of fluoroquinolone with an antacid. It needs to be separated for about 2 hours. Now, this goes for most antibiotics. Check the culture and sensitivity. We do need to pick up on our fluid intake. Watch for superinfection, Stevens-Johnson syndrome. This as well can make patients super photosensitive. Now, what's unique to this drug that separates it from the sulfonamides is it can cause tendinitis or a ruptured tendon. Very important to know. I one time had a patient that I was going to administer ciprofloxacin to, and he said, I can't remember if that's that one drug that ruptured my tendon. And I was like, wait a second, let me look this up. And I'll be darned, ciprofloxacin can cause tendinitis and or ruptured tendon. So he didn't list it on his allergy list. Thank goodness he mentioned something. I was able to get it off his MAR, and we spared him another ruptured tendon. Okay, practice question. A patient has been prescribed trimethoprim sulfamethoxazole. The nurse realizes that this drug is most likely used to treat which condition? Boom. Yes, D. Very good. Boy, you guys are good. Let's do another question. The patient is ordered to receive trimethoprim sulfamethoxazole Bactrim. This Bactrim is a combination of 2 medications that are C, synergistic, definitely increasing the desired drug response. Very good. Next one. When teaching a patient about trimethoprim sulfamethoxazole, God bless, the nurse gives highest priority to teaching the patient to increase their fluid intake, report signs of ringing in the ears or loss of hearing, expect the color of the urine to change to a reddish orange, take this drug with dairy products or in acids to protect the stomach. Ding, 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 ding. Make sure they take this drug, increase their fluid intake, because if not, they'll get what? Crystalluria. Yes, very good. I'm so glad you just yelled that out. Last question. After taking a sulfonamide, a patient develops desquamation, scaling, and itching of the skin. The nurse identifies this condition as Stevens-Johnson syndrome. Better stop that drug. That's not good if they get that. No. Alright, let's keep moving. We're already 10. Here I have a map of Italy. Yes, I do know that we're talking about antibiotics and cephalosporins, but cephalosporins began here. This is Sardinia. Off the coast of this little island, there was some fungus growing in a sewer outlet, and some scientists found that it did a fantastic job of killing gram-positive and gram-negative bacteria. So that's why it gets the name cephalosporin, because it is from the fungus Cephalosporium acremonium. There you have it. What's interesting about the cephalosporins is that they are very close in nature to what penicillin does, in that it interferes with the bacterial wall synthesis. But we don't exactly put fungus in people's body, now that I said that. It's a semi-synthetic version of it. And what's great is it produces an enzyme that stops bacteria from protecting itself. So we're going to just say it does what it does, because you don't need to know all those details, and gives it to somebody who has a urinary tract infection. And it could do a couple other different infections that you see here. Can't take care of it, I should say. And there are many different generations of cephalosporins, 4 to be in fact. Watch there be a 5th one by the time I actually get this thing narrated, but there are 4 at this current time. The first generation is a narrow spectrum antibiotic. It's primarily effective against one type of bacteria. Now, when we move on up to the 4th, these are broad spectrum, like it gets more and more broad. This also means that it kills more and it has more side effects, so keep that in your mind as well. But it treats multiple infections, and a lot of times a doctor will place somebody on a 4th generation, and then when the culture and sensitivity come back, they will then identify the organism and put them on a 1st generation cephalosporin. An easy way to think of this is, let's see if I can do it. I want to be able to do this. Is it going to let me? 4 kills more. Let's get my highlighter back here. Okay, so these are some names of very, very popular cephalosporins, and I just want to point out that most of these can take care of UTIs. This Rocephin ceftriaxone is one that most students have already given in the hospital. Another popular one that I see given in the hospital is Ansep. These oftentimes are drugs given prior to surgery, such as a on-call drug. So all of these have a ceph somewhere in it. Cephalexin, cefazolin, cephalin around here. And which one kills more bacteria? 1st generation or 4th generation? I hope you're saying 4th generation, because 4 kills more. Very Okay, I like my picture. Let me explain why. About 10% of people who are allergic to penicillin have a cross sensitivity to cephalosporins. So what does that mean? Is that if they are intolerant to penicillin, they will probably have a reaction to cephalosporin. So you don't really know whenever you see penicillin on somebody's allergy if they are within that 10% or not. And so I have this picture is you feel like this is a bomb squad detonator, or an EOD guy. Like, I think they're explosive ordnance disposal technician. So when I go in to give somebody a cephalosporin drug that has a penicillin allergy, I slowly go up to it, I slowly hook up my cephalosporin, and I cross my fingers just in case they're that 10%. So always think cephalosporin does have a cross sensitivity to penicillin, because remember, they're very alike. So in general, we're watching for pruritus. There can be a little bit of distress. This isn't limiting, but if they have diarrhea, we may have to try to give them some probiotics. Nephrotoxicity can limit the dose, and so a lot of times the doctors will give small doses all throughout the day, like Q6 hours versus like Q12 hours, with a larger dose. So it's not a contraindication necessarily. Blah, 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 blah. You get it? Did you like that? Hope you did. Worked hard to get that. Alright. So cephalosporins do have a major drug interaction with alcohol. If you have that, if you have alcohol while you're taking a cephalosporin, you're going to get something like the disulfiram effect, where you have flushing and dizziness and headaches and vomiting. Not good. So if you're on this drug, you must abstain from alcohol. Another thing too is those anti-gout drugs that we learned about a couple of weeks ago. The example here being probenecid. This to decrease cephalosporin excretion, so we actually can have somebody get toxic really quick. So these are the main drug-drug interactions I need you to know. Alright, anytime you have somebody on broad-spectrum antibiotics, please help us. Please help them and give them some yogurt, some Activia or probiotics such as the lactobacillus, or the other one, what's it called? Culturel, Fluorostore, those kind of medications to help them not have diarrhea. Restore, not destroy, they're called. These are pretty typical. Take antibiotics if you're feeling better. Take with food. Hydrate if they do have diarrhea. Oh yeah, they like that in a little skull. Side effects intolerable or itching develops. This goes for all of them. I can't isolate it just to this one. Alright, let me show y'all something cool. Do you see this? Right here, we have a urine culture that was grown, and they did a culture and sensitivity, and here is the report. And I'll be darned, E. coli, that's what they grew. And I'll be darned again, greater than 100,000 organisms per ml. So what do you think? Does this person have an UTI? Yes, sir. Alright, so when a doctor requests a culture and sensitivity report, what they do is they take the bacteria and they put it in about 14, 18, maybe even 20 something vials, very skinny little beakers, and they throw in a bunch of different drugs at different concentrations, and they test and see which drugs work in the lowest concentration and have the most bacteria kill. Let me say that again. Which drug works in the lowest concentration and gives the most bacteria kill? So basically, what little bit goes a long way. Yeah, that's a better way to say it. Should have said that first. And so I know a couple of times when I had the culture and sensitivity report come back, the doctor says, okay, so what is it susceptible to? And you're left staring at this saying, you know what, that's a great question. I have no stinking idea, doctor. Open the computer and read it yourself. But I'll give you the quick little down low. First, start with, oh, come on. Well, that's no fun. Yeah, there we go. That's better. First, start with where it says S and the less than number. Those are the drugs that you want to take a peek at first. And I've highlighted all of those. Notice the majority of them. So anywhere where it says this, as a nurse, this would be the drug that I would rattle off to the doctor. here where it says S with just a number, such as this one and this one, this means it's effective but not really the best one to choose. So as a nurse, what I would like you guys to know is pick a S with that less than number. That's how you know it's effective at the lowest dilution tested. Don't really pay attention to the numbers. Don't. You're going to waste your time and energy. My focus is to have you guys read that section right there, and that's what you're going to read off to the doctor. All right, doc, we can do amikacin, cefotoxamine, cefatizidine, cetraxone, blah, blah, blah. And then if you have a patient with allergies to all of the green, then you can mention that one and that one. Please don't read off the ones that have an R next to it. Take a guess what R means. Yeah. Take a guess. Resistant. So, you're not doing anybody a favor. Good job. Last thing we need to cover is that the patient will probably be getting a urinary analgesic. I know I mentioned this and I was not able to pronounce, I think, the name in class, but phenazopyridine. Once again, you'll get one more chop at this from me. Phenazopyridine, or pyridium is probably much easier to say. This is great. If you notice, it does turn your urine a nice hot orange. It can give somebody a little bit of a GI upset, but if they take it with food, they're fine. My big thing on this drug is it causes harmless red-orange urine. Not a big deal. And that you can't give it to somebody who has these problems. We good? Good. The last little drug group that I wanted to mention are the urinary antispasmodic and anticholinergics. And anytime you hear these two here, I want you to think of this little jingle because that is a major limiting side effect for any type of anticholinergic drug or any drug that is in the antimuscarinic drug class, because it halts the parasympathetic nerve impulses, such as the like it stops the rest and digest system. So people who have glaucoma definitely don't need this drug. People who have like a urinary obstruction, such as a kidney stone, or if they have BPH, do not give them this drug. Or if it's a complete blockage, definitely don't give them this drug. This one I know is over the counter. It is good because it does suppress the involuntary bladder contraction, so somebody can pee when they want to pee, not just, their bladder spasming, maybe from the UTI. And Detrol, this one is a prescription drug. I've seen Detrol more or less given to like older ladies who have stress incontinence, but also known as overactive bladder. But it can also be given for people who have UTIs. So, takeaways, over the counter. Don't give it to them if they have that, or if they have, a GI obstruction. Maybe they just need to take more fiber and they can combat the constipation that can happen.